Hello, my name is Morie Gertz. I'm professor and chair of the Department of Medicine at Mayo Clinic in Rochester, Minnesota. I've had a quarter-century interest and experience in the diagnosis and care of patients with multiple myeloma, along with the myeloma group at Mayo Clinic at all three sites, Rochester, Arizona, and Florida. Our job today is to explain what multiple myeloma is. Multiple myeloma is a cancer of the plasma cell. It occurs 8 per 100,000 per year and will affect 19,000 Americans in this calendar year. The plasma cell is a cell that exists in the bone marrow, and the bone marrow is that area inside the bone that is responsible for the production of all of the body's blood. There have been remarkable advances in the treatment of multiple myeloma over the years. And although multiple myeloma cannot be cured, either can arthritis or high blood pressure, but multiple myeloma can be managed with highly effective treatments, often given sequentially, that have significantly improved the outlook and prognosis for patients with this disease. Your physician diagnoses myeloma by a series of blood tests, x-rays, urine tests, and in most instances a bone marrow examination. The physician seeks an increased number of the abnormal plasma cells in the bone marrow, as well as the presence of an abnormal protein which can be present in the blood or in the urine or both. X-rays of the bone are generally done to determine if there are any abnormalities on the bone x-rays consistent with multiple myeloma. Your physician will also use testing to determine if there's any evidence of anemia, elevation of the calcium in the blood, indication that kidney function may be impaired, and occasionally a high level of uric acid in the blood. The majority of patients with multiple myeloma produce an abnormal protein that can be detected in the blood or urine or both. Serialized measurements of this protein are useful to assess the activity of the disease and indicate in part whether treatment is required. Multiple myeloma can affect the body through a number of ways. The most common are an impairment in the production of red blood cells, which results in anemia, usually manifest as increasing fatigue, shortness of breath, and tiredness. It may affect the integrity of the bone. That can lead to back or rib pain, or in rare instances, a fracture of the bone. It can also impact on the function of your kidney, and that can reduce the purifying function of your kidney, which can be detected by your doctor using specific blood tests. The major determinants for the need for therapy include damage to the bones, progressive decline in the blood count causing anemia, or impairment of kidney function. It's important to recognize that treatment is never dictated based on the protein levels alone. Although protein levels can often be diagnostic for multiple myeloma, they are not necessarily a determinant for when therapy needs to be initiated. Following the protein is important, but the clinical manifestations of the disease on your blood counts, on your kidney function, and on your bone are keys to determining whether you should be treated or monitored closely. There is a subset of patients who have smoldering multiple myeloma. They fulfill all of the criteria for multiple myeloma: high plasma cell counts in the bone marrow, abnormal proteins in the blood and urine. However, they lack symptoms. Patients are feeling well, they have no fatigue, anemia, elevation of the blood calcium, excellent kidney function, and no damage to the bones. When this occurs, patients can be safely monitored and treatment is not required. When therapy is being considered, one of the first considerations is whether you are a candidate for consideration of high-dose chemotherapy and stem cell transplantation. There are certain chemotherapy medications that make it difficult to subsequently proceed with stem cell transplantation, and the treatment that you receive will depend upon whether you are or are not a candidate for stem cell transplantation. Only you and your physician can make that determination. Age is one of the relevant considerations. How robust you are, whether you have any other associated heart or lung conditions, may all be important issues in determining whether stem cell transplantation is appropriate for you. For patients who are not being considered for stem cell transplantation, the most common regimens include the use of the oral drugs melphalan and prednisone combined with either thalidomide, lenalidomide, trade name Revlimid, or bortezomib, trade name Velcade. Thalidomide and lenalidomide are oral medications as well. Velcade is an intravenous medication. These are the mainstays of treatment for patients who are not being considered for stem cell transplantation. For patients who are being considered for stem cell transplantation, melphalan is not an appropriate choice, and the majority of specialists in this area use dexamethasone combined with lenalidomide, trade name Revlimid, or bortezomib, trade name Velcade. There are instances where the use of dexamethasone with thalidomide may be used as well, and these constitute the most common initial regimens leading up to stem cell transplantation. Stem cell transplantation is a technique that allows your physician to administer very high doses of chemotherapy that would not be possible without the precaution of stem cell collection to avoid excessive bone marrow damage from the use of the high-dose chemotherapy. Stem cell transplantation is not for everyone because it is a rigorous procedure and it can have significant side effects, and it does carry specific risks that you will need to discuss with your physician, but include serious potential for infection, bruising, bleeding, and the need for transfusional support for a period of 2 to 3 weeks. There are many controversies that are currently in existence on the utility of stem cell transplantation. With the introduction of novel therapies, the exact role of stem cell transplant remains undefined, despite the fact that it is a known effective technique. However, whether transplantation should be done at diagnosis or reserved for a later date, or whether more than one transplant is appropriate, all remain questions. There are also issues where there are certain patients, based on the biology of their disease, would benefit more or less from the use of a stem cell transplant. All become considerations in determining which individuals would derive the greatest benefit for stem cell transplant. The introduction of the new or so-called novel therapies, thalidomide, lenalidomide, trade name Revlimid, and bortezomib, trade name Velcade, have changed the landscape of care for patients with multiple myeloma and have rendered the questions regarding when stem cell transplant is and is not appropriate far more complex because of the excellent results that are occurring with these medications. The recent introduction of these new agents makes it difficult to be certain about what is the best combination, best interval, total duration of therapy that is appropriate. What is clear is that since the introduction of these agents, the survival of patients with multiple myeloma is significantly prolonged and their outlook is substantially better. Moreover, the development of these agents now provide a platform for the development of more potent agents that have less side effects but still take advantage of the mechanisms to kill multiple myeloma cells. Extensive research is underway looking at new derivatives that work in a completely different way that will likely provide additional benefit for patients with multiple myeloma, suggesting that the future is actually quite optimistic for long-term, high-quality survival.